All right, here's lesson 24 on the EMT course. We're still in the cases E unit where we're dealing with a bunch of altered mental status stuff. This one's a little bit longer online, and then we do a bunch of stuff in the lab again. So continued emphasis on altered mental status, and particularly this one is concerning poisoning and overdose in general, and a lot of time and emphasis on opiate and opioid and the administration of Narcan and that whole topic, which we have quite a lot to discuss, and we need to make sure that we're very clear on this up front. Altered mental status in general, again, emphasizing, let's rule out hypoxia. Let's find shock. Let's measure their temperature, if nothing else, with qualitatively with the back of your hand, but preferably with a thermometer. Let's always consider sepsis. That's mostly going to be on a history of present illness. Let's always check glucose. There's no excuse for not checking glucose temperature and pulse ox on your altered mental status patients. And then let's consider that it could be drugs that they bought off the street, or prescription medicines that they're abusing or accidentally overdosing themselves on, and alcohol. It could be a trauma or a stroke or some neurological thing, including seizures. Remember all those things, and then remember again that it can be more than one thing. So just because you found one thing doesn't mean you should stop looking for all the other things. Altered mental status assessment goes on while you're managing CVO. Be an EMT before you play detective, but get that CVO taken care of. More than one cause may be present. Always rule out those obvious three things. And then part of your detective work includes the history of the present illness as best you can determine it. Sometimes your altered patient doesn't give you the very best history, and if there's no one else around, then you're kind of stuck. But that's where your history and physical come in, and clues from the scene and past history. And as you start to go on more calls, you will be able to start recognizing patterns. Now, we start that in the EMT course where we do scenarios and case presentations. And so you're not actually experiencing a real call, but you can start putting together some of these patterns. Pattern recognition is awesome. It's the first thing that pops to your mind is frequently the right thing, or at least one of the right things. There's nothing wrong with pattern recognition. You're profiling more or less. You're putting together a series of tidbits, a series of clues that you are putting into a picture, and you're arriving at what you think it is while you're managing CVO. The problem is tunnel vision. Tunnel vision in this context to us means that you found low blood sugar and you said, wow, I've got it. I've guessed the puzzle, and that's all it is. It's low blood sugar. But that's not appropriate, and that's not good patient care. And so we want you to recognize patterns and jump to a conclusion. Here's what I think it is, and then spend a bunch of time trying to prove yourself wrong. Let's make sure you never miss one, even though you jump to the answer and you probably get it right, and you may be right 90+% of the time. It's that few percentages of the time that you can really get into trouble. So pattern recognize is great. Pattern match. Move on to a usual plan, a usual script of what you do, but avoid tunnel vision. Avoid believing that just because you found one thing means there isn't anything else. Usual oxygen protocol and altered mental status. There's nothing that says that a non-rebreather for everybody makes any sense. I think I could be okay with an altered mental status getting a non-rebreather to start with while you do some of your further investigation. Let's make sure we don't withhold oxygen unnecessarily, but at the same time, let's be smart, use our usual oxygen protocol. Consider the cause, manage the causes that you can deal with. At the EMT level, there's a couple of them. And always protect the patient and protect yourself. Patients that are altered may not realize that they're as out of control as they really are. So a toxic exposure, and again, we're going to spend a lot of time on opiate and opioids in this lesson, but we're going to talk about toxic exposure in general. And this concept of a toxidrome, and there are 5 of those listed here. There are a few others that are pretty strange and rare and not really at the BLS level. But the 5 we're going to talk about are anticholinergics, cholinergics, opiate, opioid, the sedative hypnotics, and the sympathomimetics. And that seems like a lot of terminology, but you know what? At the EMT level, you are an EMS professional, and medical terminology is part of your deal, and so you have to figure that out. Yes, we would like to decontaminate these patients, and in some cases that's appropriate, and in some cases there's an actual antidote. But basically, the toxidromes concept means that if a patient is exposed to a cholinergic substance, the symptoms are going to be the same regardless of what specific substance it is. So you can group toxic exposures into groups, toxidromes, and the assessment and management of those is pretty much the same regardless of the specific agent. So let's talk about opiate and opioids and the toxidrome for opiate opioids. And so these are heroin, morphine, synthetic versions of the same. They all go to the same brain receptor. That brain receptor that these attach to produces a feeling of relaxation, of pleasure, of relieved pain, and they also tend to slow breathing. So while we would like our patients to be relaxed and having a pleasurable, pain-free experience, we would also like them to keep breathing. So the problem with these is that we end up with hypoxia. And so the opiate-opioid toxidrome key thing is we've got to correct the hypoxia because that's what's going to kill them. Otherwise, they can be relaxed and feeling fine, but they have to be breathing and they have to maintain oxygenation while they're doing that. So excessive activation of that receptor slows or stops breathing. That produces hypoxia. That's the big deal. If you're assessing this patient, of course, you're going to use HPI and scene clues, and many times that will reveal what's going on. If you arrive at a call and the patient is on the bathroom floor and there's a syringe and a spoon and a lighter, and you're told by the family that this patient has a history of heroin abuse, I don't think it's a real difficult leap of faith to say, well, this is what this probably is. So I recognize that pattern, and I've moved toward that toxidrome. But really, what are the steps in that? The steps in managing this patient are fix the hypoxia, which you can do with airway management, oxygenation, and ventilation. And then in this case, there may be a specific antidote that's available. Rarely is that the case. But in the case of opiate and opioids, there's a specific antidote for this situation that you can administer while you're managing ventilation, oxygenation, and doing the basic CVO sort of stuff. Also, a little note here, there's not real good quality control in the drug industry, meaning the street drug industry. So what you bought, you thought was heroin, but it probably wasn't straight heroin, or it may be much stronger than you used to get. Maybe your dealer has a new supplier. Maybe you have a new dealer, and they're teaching, or they're telling you, they're selling you on that this is heroin, but it's a mix of other stuff. Maybe other stuff that's psychoactive. Maybe it's other stuff that gives you a better buzz. Maybe it's other stuff that causes your body to quit breathing more rapidly or stay apneic or in respiratory failure longer. You don't really know what was in it. So it says it's, you're told it's heroin, but it could be lots and lots of stuff. So antidote-wise, for the opiate-opioid toxidrome, there is an antidote. It's called naloxone. Street name or trade name is Narcan. And what does it do? Well, it attaches to those very same receptors, but it doesn't activate them. Whereas the heroin hits that receptor and causes that receptor in the brain to take an action, feel relaxed, feel no pain, get a buzz, be high, and stop breathing. When the Narcan attaches to the receptor, it doesn't make any of those things happen. The patient doesn't feel better from taking Narcan, but they also don't stop breathing. So the idea would be is for us to give them some Narcan and try to get Narcan to attach to a bunch of receptors rather than heroin attached to a bunch of receptors. The problem is that Narcan doesn't hang on to that receptor. It hangs on to the spot for a while and blocks any heroin from hitting the receptor, but it tends to wear off and fall away, and then the heroin is still hanging around and it attaches to that receptor. So just because you gave someone Narcan and their breathing is back and they're nodding or they're starting to wake up, or worst case, you gave them too much and now they're fighting and vomiting and they're in withdrawal, the Narcan's going to wear off and the heroin's still going to be hanging around. Narcan is pretty safe, but it's not without risks. There are patients who can have extreme tachycardias. There are patients who can have bad pulmonary edema. Narcan administration is not without risk, although those are relatively infrequent. We have seen them locally. Just members of a faculty team, just a small group of us have personally seen them. And so Narcan is not like water. You shouldn't just give it to anybody and everybody. You should hold it until you need it. There are side effects and there are risks. And so you should be aware of those and be smart. It is not as simple as, oh, he has taken heroin, I'm going to give him Narcan. It's not that simple. In many cases, you can get away with not even giving Narcan if you will manage their oxygenation and manage their ventilation. And while this is my strong personal opinion, and it is shared by members of our EMS Ed faculty team, it's also backed up by research and shared by most street medics and most ER docs, including medical directors in our system. So when we first deploy Narcan in a system, it tends to be the end-all, save-all, and everybody feels like they're not a real EMT unless they've given some Narcan today. And I wish that hadn't happened, and I hope it doesn't happen in the future. So we're going to try to educate our way out of this little situation that we've gotten in. The other thing is that Narcan does not reverse a cardiac arrest. So if your patient is in cardiac arrest and they have taken an opiate or opioid that has caused them to stop breathing and they've gotten hypoxic and their heart has stopped because of that, just giving them Narcan is not going to start their heart again. Their heart didn't stop because of the opiate or opioid. It stopped because of the hypoxia. You've got to fix the hypoxia before you can fix the arrest. So there is a point in cardiac arrest management where consideration of the cause and management of the cause is appropriate, but not right off the bat. It's the basics of CVO, which in cardiac arrest would include defibrillation and chest compressions. Next thing, it would be great if we could give Narcan IV, but at the BLS level and the lay public, they can't give it IV. We like to give things IV because we know exactly how much they got and we know when they got it. But if we have to give it via the intranasal, the IN route, we don't know exactly how much they got or when it started to soak in, because there's snot involved and there's a difficult administration involved. IV, you put it in a syringe, you squeeze the syringe, the medicine goes in the IV, it's pretty straightforward. If you could start the IV at the EMT level, you would really enjoy giving Narcan IV because you would know how much they got and you would know when they got it. But we're stuck with this IN route. And there's two issues there. One is snot. And snot is a normal thing. Snot's a good thing. Snot lines your airway from top to bottom. Starts in the nose, but there's snot all up and down. And if we're trying to get into the nasal mucosa and get these little tiny droplets of Narcan to soak in to the nasal mucosa, and the snot is coating the nasal mucosa, well, we're not really actually delivering Narcan to their nasal mucosa. We're actually just squirting it into the back of their throat and they swallow it. So that doesn't work. IN meds absorb more slowly, although pretty quickly. So it's rapidly enough to be a useful route. I'm not saying that IN is a bad route. I'm saying that IV is a great route, and IN has some problems. As a paramedic, if I could start an IV rapidly, like in a minute, I would give Narcan IV. I wouldn't give it IN. But if I can't get an IV rapidly, or in the case at the EMT level, or in a place where even if you are an ALS provider, you're constrained and can't practice at that level, if I can't get an IV, or I'm not allowed to start an IV, then I'm stuck with IN, and it's not a bad route, it's just not the best route, and there's some issues. The delivery through the little atomizer device, the MAD device, the mucosal atomization device, is nice. It makes a very fine spray, and we'll show you that in lab and let you spray. But the problem is that you have to give a forceful push on the syringe in order to create that spray. Otherwise, you get drops. Drops roll down the back of their throat and they're swallowed, and that's not how Narcan gets absorbed. You need the spray. So you have to be able to give a forceful squeeze of the syringe in order to make the spray, which then means it would be great if we could use the whole syringe. The problem is the way that many places carry Narcan, a whole syringe is probably way too much Narcan. And so you would need then to be able to draw it up into a different syringe, and a lot of places don't have the equipment for that and don't teach that. So you're taught to just grab this preloaded syringe and push really fast but come to a screeching halt at just the right place. And I'm telling you, if you haven't tried to do this, that's very, very difficult. I can't do it very effectively, and I've been doing this forever, and I struggle with this. And if you're not familiar with syringes and delivery and you haven't done this a whole bunch of times, it's even harder for you. So you end up giving more than you meant to, or you end up giving drops when you meant to give a spray. And it's just not a very effective route. IV would be so much better, but we're stuck with IN. All right, now the next question, what is the right dose? Well, nobody knows, because nobody knows what this guy put in his body. Even if we knew the exact amount of heroin that he put in his body, the exact dose of heroin, there's not research and evidence-based medicine that will tell us what the proper dose of Narcan is to reverse an exactly known dose of heroin. And obviously we have no idea what they took or how much they took. And so this dosing of Narcan is a complete shot in the dark, and you just have no real idea. So, how much would you like to give? Well, you would like to give just enough so you can put your bag valve mask down, but not so much you put the guy into withdrawal. Withdrawal is writhing in pain and seizures and vomiting and angry, and it's ugly, and we don't want that. But we have no idea what the right dose is because we don't know how much he took. And even if we knew how much he took, we don't know the particular chemistry in his body at that moment and how much Narcan is needed. So it's very difficult. So our plan is to give just enough to where you can put the bag valve mask down. And remember that if you don't have the bag valve mask in your hand, then your patient does need to be ventilated. Excuse me. If you don't have the bag valve mask in your hand, you shouldn't have the Narcan in your hand. Patients that don't need to be ventilated don't need Narcan. It's that simple. Just because they took an opiate or opioid doesn't mean they need Narcan. Narcan is so that you don't have to ventilate them. So how do you know how much? It's really hard to guess, but here's the deal. You can't suck it back out. So if you'll start with lower doses, smaller doses, or increments of what you think is the right dose. Like if you think the right dose is 1 cc, and you give them a quarter of a cc or a half of a cc, and that works, great. If it doesn't work, then give them another quarter or another half. It's called titrating to effect. You give them just enough, but realize you can't suck it back out. How does it come? Well, some places are carrying a 4 milligram nasal spray. That is a humongous dose that is very easy to administer because it's just like a nose spray. And anybody who's ever had a stuffy nose then would know how to give this Narcan. It's not the atomizer device and the syringe. It is a one dose, give it all, very intuitive, very quick, very easy to give. The problem is that it's 4 milligrams. That's probably 10 times a reasonable starting dose. In my mind, it's 20 times my reasonable starting dose, but I may be weird on this. But for many, many years, for 30 plus years, the starting dose for Narcan has been 0.4 milligrams, not 4. So that's a humongous dose, but easy for lay public and cops and people to give. And so it's out there. It's in our system. It's out there. On the fire district currently, we use 2 milligram preloaded syringes. Those are the same preloaded syringes that the medics carry, and they give IV. And that's great for ALS use, and it's okay for ALS to use it IN because they could draw it up in a different syringe. They've got more syringes. They have been trained to draw medicines up. They have the adapter to go between the preload and a regular syringe. And so if I were working as a medic, I would have syringes and adapters, and I would be happy to give IN if I couldn't get an IV, because I would give the dose that I wanted. I would just draw up a little bit, and I would empty the whole syringe that I had drawn up, and I'd get a good spray, and it would make some sense. If I'm stuck with this 2 milligram preload, then, and I can't get into a smaller syringe, then I've got to forcefully spray and then stop at just the right point. And I've tried it. In the lab, I've tried it on real patients. I can't pull it off. It's very difficult. So what you're going to end up doing, if you're stuck in this world, is you're going to end up doing the best you can. And I just need you to realize that you may overshoot and give too much, or you may have uncertain absorption, and it's just kind of a very vague thing that we are stuck with in a situation where you can't start an IV and you don't have any way to get out of these large dose syringes. So anyway, that's our sermon on that. And again, this is my strong opinion that is shared by all the faculty team and the medical directors. And it's just that we're stuck in a logistical problem here. And that's why we're doing what we're doing currently on the fire district. So how do you deal with opioid treatment? Well, CVO. And again, if you don't have the bag valve mask in your hand, then you should put the Narcan down. I recently went on a call where the patient was breathing 6 or 7 times a minute and had blue lips. And I did a jaw thrust and positioned his head in a good sniffing position and reached for what I thought was going to be handed to me was a bag valve mask, and they handed me Narcan. And I said, I don't want that. I don't need that yet. I'm going to oxygenate and ventilate this guy for a couple of minutes. And if that doesn't bring him around, then I'm going to decide that, well, after 2 or 3 minutes of bag mask ventilation, another 2 or 3 minutes, it's going to start causing some gastric distension, and then we're going to get some puking. And so I need to not be bagging this guy without a good airway, without a king airway or an endotracheal tube. I need to not be just doing bag mask ventilation for 5 or 6 minutes. I gave him 2 or 3 minutes. He didn't come around. I gave him some Narcan. He came around. I put the bag valve mask down, switched to a non-rebreather, and everybody went on with their life. So we would like them to have lots of oxygen. Lots of oxygen. So if you're using a non-rebreather mask, have it cranked all the way up. If you have a situation where you can use a nasal cannula under a non-rebreather mask, a lot of places are doing that. Now, in the fire district right now, that's not in our protocol. But lots of oxygen would be great. Not a lot of ventilation. So I don't need to ventilate this guy any faster ever than 10 times a minute, and probably could get away without even ventilating him in some cases. Just that's not within protocol. So lots of O's, easy on the vents. Use your pulse ox as a guide. Use your pupils as a guide as well. These guys are going to have very, very small pupils, and as you start to get them to come back around, as the opiate starts to wear off, or if you've given Narcan, as the Narcan starts to kick the opiate off of the receptors, then their pupils are going to get a little bit bigger. So you should start seeing pulse ox rising, ventilations rising, patient movement rising, and pupils increasing all at about the same time. Narcan in small doses, use your protocol. If I was doing it IV, I would start with 0.1 or 0.2, and I would give 0.1 or 0.2 IV every couple of minutes until I could put the bag valve mask down. I've never had to give more than 4 milligrams, and that's only been one time. We do know of cases where the supposed heroin was adulterated with fentanyl or something, and they had to go up to 10 and 15 milligrams of Narcan. These are not common. They're not common in all systems. They are common in some systems, but it depends on who your heroin suppliers are locally, and of course we have no way to change that. So the typical IN dose, intranasal dose, is going to be 0.4 milligrams or 0.5 milligrams, depending on the system, and that may be way too much, or it may be not near enough, but it's I suppose a reasonable starting dose. So that's our sermon on opiates and opioids. It's important that you take away from that if you're not ventilating the patient, then put the Narcan down. He doesn't need it. If you're trying to give Narcan and you're not ventilating, you need to be thinking about why that is. Ventilation should come first. And one additional note to that, there's some pretty clear evidence that if we will oxygenate and ventilate before we give the Narcan, that we can reduce the likelihood of some of those bad side effects that occur occasionally. So a real good plan to minimize your patient's risk in this situation is to oxygenate and ventilate first for a couple of minutes. Anyway, there are many other toxidromes. I'm just going to spend a couple of minutes on this. And so remember that even your opioid patient could have some of these substances in them if they have been doing more than one substance, or what they thought was heroin was not really straight heroin. And then this also then applies to your general poisoning exposure sort of patients. So the cholinergics, this would be something like mushrooms, organophosphate pesticides, nerve agents. Again, probably pretty uncommon you would come in contact with this. Not sure you're going to be able to pull it out of your brain at the time that you need it. But these patients can be a mess. They can be very bradycardic, very slow heart rate. They can have a lot of bronchial secretions, that's bronchuria. They can have some bronchospasms. So they have problems with circulation and with ventilation and with oxygenation. They're also going to have pinpoint pupils. They're going to be very teary. They're going to have some GI stuff, diarrhea. They're pooping on themselves. They've got a bunch of cramps. They're vomiting, and they look sick and they're a mess. The acronym that's been around forever is SLUDGE: salivation, lacrimation, urination, defecation, GI symptoms, and emesis. I don't know if that helps you remember them. I remember it because I have to teach it. I'm hoping I would remember it when I'm at the patient's side. But these patients they're a mess. And there's secretions everywhere. There's secretions coming out of their eyes. There's secretions in their lungs. They're pooping on themselves. They're peeing on themselves. And they're just out of control and a mess. At the BLS level, what do? You suction and you oxygenate and you ventilate and you do the best you can. Then there's the anticholinergics. This would be maybe some antihistamines, maybe some of the tricyclic antidepressants like an amitriptyline or a nortriptyline. Some of the newer antipsychotics, Zyprexa is one of the ones that's in the literature. And so a history of present illness, what did he take? And while you're managing CVO, you're doing some investigation. When the investigation reveals that, this patient has overdosed on amitriptyline, then they can be, patients can be very, very dry, very tachycardic, sometimes so fast that it's creating hypotension. They can have weird reactions where they're picking at themselves. They look almost like they're if you've ever seen somebody on meth that's tweaking, but they're picking at themselves, they're pulling off the pulse ox, they're taking off the blood pressure cuff. They're just a real pain to manage. They have very large pupils that are very slow to react. and they're dry, cotton-mouthy, and they're altered, but you can get them to focus for just a few seconds, and then they're gone again, and they're off talking. So they will answer questions, but then they're out in left field again, and they're bouncing around, and so this is kind of the whole anticholinergic tox syndrome. What can you do at the BLS level? Well, you guessed it. Treat the symptoms that you see, protect yourself, and work with it. Sedative hypnotics, that's the benzos. These are not as commonly seen as drugs of abuse, but GHB also fits in there. GHB was one of the first date rape drugs that came around. It's a particularly nasty substance. It used to be used as a metal cleaner, and then people decided that if they would spike somebody's drink with them, that person would then become unable to defend themselves, and that's where the date rape drug came in. It can also be Xanax. Xanax is a very common anti-anxiety agent that many patients take in a pill form, and so if you were to overdose on Xanax or add Xanax to some alcohol or some marijuana or whatever, or both, you could end up being extremely sleepy. But the good news is that you probably won't quit breathing. So your patient that's very altered level of consciousness, responsive to pain only, in some cases unresponsive, but breathing adequately, that's kind of fits the picture of these kind of folks. Now, certainly Valium given IV or midazolam given IV, which the medics do, when you give it IV, you can get some respiratory depression, but typically in the oral forms, not so much. And they can take a whole bunch of Xanax or a whole bunch of Valium pills and not be in real ventilatory trouble. And even if they are, you can bag them, you can still oxygenate them. And these are very peaceful patients for the most part. Now, the GHB patients, in my experience, look very, very sleepy and very, very unconscious until I tried to intubate them. And so by stimulating their gag reflex, stimulating the back of their throat, they came alive and tried to kill me. And then when I would stop messing with them, then they would go right back to sleep. So GHB is kind of difficult in that way, but these patients look very unresponsive, but yet they're maintaining their ventilation. So again, what do you do at the EMT level? CVO. Sympathomimetics, that's a pretty good Scrabble word, maybe hard to say. What this is things that act like adrenaline in your body that aren't adrenaline, like coke, meth, well, cocaine, not Coca-Cola, but cocaine, methamphetamine, those kinds of things. And the big deal there is why I put it in capital letters. These patients are hyperthermic. They are very, very warm. And they don't feel pain and they don't get exhausted. And so they will fight to the point where they have a bunch of lactic acid buildup and they're very tachycardic, they're hypertensive. In really severe overdose cases, strangely, of these uppers, of these adrenaline mimics, they can get hypotensive, but in most cases they are hypertensive, tachycardic, and very, very warm to the point where they can be dangerously warm and need to be rapidly cooled. They can be very paranoid, they can be very psychotic acting, very agitated. This can lead to seizures. And so what are their pupils doing? Well, their pupils are dilated for other reasons than low light. So normally a patient in the dark is going to have dilated pupils. These guys have dilated pupils in regular light. If you can shine a light in there, that pupil will constrict. But without stimulation from direct light, if they're just in ambient light, their pupils are going to be huge. And so that's coke or meth. And so, again, these things are a mix. We just saw a patient the other day that we're going to make into a case for the paramedics where he had a mix of all of these things and plus alcohol. And it was very difficult to categorize him into any one toxidrome. And so, the treatment's the same anyway at the BLS level, So we contain, we protect, and we manage CVO if we need to, and we just make sure that we're there in case anything worse happens, like he seizes or goes into arrest. So anyway, tox can be an entire course. We could spend hours on this. But at the BLS level, we've tried to whittle it down and summarize it. It's one of the many causes of altered mental status. The way to deal with altered mental status is manage CVO. Always, always, always rule out hypoxia and hypoglycemia. Measure that body temperature, see if it's way high or way low. If you don't have a thermometer, at least touch your patient with a non-gloved hand and have some skin-to-skin contact where you can check. And as you saw in the sympathomimetics and in some other cases, extreme hyperthermia, it's a big deal, and you need to know that it's going on so you can step in. If you're pretty sure that your patient is taking an opiate or opioid, or if you're not sure and you're having to ventilate, then maybe some Narcan, just in enough that you can stop bagging them, would be appropriate. So I guess the situation where you're going to have a tough judgment call is you have no idea what they took, and you're stuck with, well, this needs to fit a toxidrome, so what am I going to do? And, the ones that cause respiratory depression are pretty much the opiate opioids. And so while Narcan does have side effects, in the unknown situation where you are having to bag the patient, it's reasonable to give. In the known situation where it's opiate opioid and you're having to bag the patient, it's reasonable to give. It is absolutely not reasonable to give it just because you believe that they have taken an opiate or opioid. BLS care for everything is CVO. In the opiate opioid, you can add that specific antidote of the Narcan. And in every case, let's check, manage CVO and rule out hypoxia, hypoglycemia, and hypo or hyperthermia. So I hope I've said it 26 times and that's helpful. My goal is that when you're at the patient's side at 3 in the morning, 2 years after you've gotten out of class, that you're still so irritated with me that you hear my voice saying, well, CVO, 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 rule out hypoxia, rule out hypoglycemia, and hey, let's measure his temperature. I'm hoping that that's the case. And so we're going to stop this now, and we'll see you in lab where we'll preach the same sermon some more.